Purohit. I'm one of the neurologists here in Scarborough. I also have an office in North York, and I work at the Toronto Western Hospital Epilepsy Clinic. So I thought I'd give you just some basics on epilepsy and seizures in general. The WHO says that approximately 15 million people worldwide have epilepsy. According to the CLAE, about 300,000 Canadians have epilepsy. Epilepsy tends to occur in two peaks that can occur at any age. We see peaks in the very young, usually less than 10 years old, often the first couple years of life, as well as the old. So after about 55, we often see another peak in people developing epilepsy. The proportion of the population with epilepsy is about 4 to 10 per 1,000 people. The lifetime risk of having a single seizure is about 8 to 10%, and about a third of those people will go on to develop epilepsy, so about 3% chance of developing epilepsy. I think before we understand what epilepsy is, it's important to know, what a seizure is, right? Seizure is a term that's thrown around quite a bit, often encompassing a lot of different clinical symptoms, but an epileptic seizure is a transient occurrence of signs and or symptoms due to abnormal excessive or synchronous neuronal activity in the brain. And then what's epilepsy? According to the ILAE, epilepsy is a disease of the brain defined by any of the following conditions. So at least 2 unprovoked seizures happening more than 24 hours apart. So if you had 2 or 3 seizures within that 24-hour period, that wouldn't qualify for epilepsy. But if you had a single unprovoked seizure, but the probability of having further seizures is similar to those who have had 2 unprovoked seizures over the following 10 years, those would also qualify for epilepsy. And there's a lot of different factors that go into when one unprovoked seizure may carry that increased risk. And usually that boils down to what the workup reveals, whether it's EEG, MRI, or even clinical history. And then there's diagnosis of an epilepsy syndrome, often based on kind of clinical symptoms and EEG. And then I kind of put this on this slide, even though it doesn't really tell us what epilepsy is, but epilepsy is still considered resolved for individuals who have had an age-dependent epilepsy syndrome, but they're past the applicable age and they're seizure-free. That doesn't really apply to us so much because we're dealing mostly with adults, but that's more in the pediatric population. Sometimes with childhood absence epilepsies and different epilepsy syndromes such as that. But more so for the adult population, it's those who have remained seizure-free for the last 10 years and have been off medications for the last 5 years. Those would be considered resolved cases of epilepsy. And then why do we say 2 unprovoked seizures? So the risk of having another seizure when there's been a single unprovoked seizure with a normal workup is about 40 to 52%. That risk of recurrence is the greatest within those first couple of years. Once you've had a second seizure, that risk goes up to about 73%. And that's over that next 4 years where that increased risk of further seizures occurs. And then with those people who have had the single unprovoked seizure, what increases that risk of a recurrent seizure? So if there's a prior brain insult, TBI that's led to intracranial hemorrhage, prior stroke, epileptiform discharges on the EEG, abnormalities on the CT or MRI, and then nocturnal seizures will also increase the risk for recurrent seizures. I've seen some neurologists, even with a single unprovoked seizure, if it's been a nocturnal seizure, start anti-seizure medications. I don't tend to do that unless the workup is abnormal, but it's not wrong because the a nocturnal seizure does increase the chance of recurrent seizures. So then, we know what epilepsy is, what wouldn't be considered epilepsy. So Children, when they're from the ages of 6 months to 6 years, if they've had a simple febrile seizure, which would be something lasting less than 5 minutes, no focal features. They may have recurrent febrile seizures, but we wouldn't call that epilepsy. We would essentially call those provoked seizures. And then other provoked seizures, more common in the adult population, are alcohol withdrawal seizures. We see a lot of these people come into our ER who are alcoholics, have had multiple alcohol withdrawal seizures. We wouldn't put them on medications. We wouldn't consider that epilepsy. We just need to work on the alcohol. Toxic or metabolic provoked seizures, drug reactions, hypoglycemia, severe electrolyte abnormalities. We typically look at sodium, magnesium, but multiple electrolyte abnormalities, calcium, hypocalcemia can cause seizures as well. And then syncope and arrhythmia. Oftentimes they can look like epileptic seizures, actually, such as convulsive syncope, and those wouldn't be considered something that would count towards our history of unprovoked seizures. Acute convulsive concussion. I don't know if any of you watch basketball. A few years ago, Blake Griffin had a concussion when his head hit the court, and he had a brief convulsion with that. Looked, very much like a seizure, but it was due to that acute concussion that he had. Seizures within that first week of brain trauma, some kind of infection like a meningoencephalitis or stroke. Oftentimes we will put people on anti-seizure medications during that acute period if they're having recurrent seizures, but we often long-term will take them off. The time course when we take them off, you'll hear different neurologists and different epileptologists say different things. Some people wait 3 months of stability, some 6 months, some people a year. Very conservative will wait 2 years. And then there's a lot of mimics for seizures as well. We get these complicated migraines that have these hemisensory phenomenon, these unilateral motor symptoms at times. Narcolepsy with cataplexy sometimes gets confused for seizures. And then we have the functional and dissociative seizures, or, old terms are pseudo seizures or psychogenic non-epileptic seizures. We're favoring more the term functional dissociative seizures because neurologists and especially epileptologists like to overthink things and change terms every 3 years. For seizures and epilepsy, the history is probably the most important thing, right? Seizures often will have some kind of evolution of symptoms. They can begin with an aura, which is often a subjective sensory or psychic phenomenon. And it's important to remember that auras are seizures, right? I think that patients, doctors will kind of brush them off and say, oh, they've just had a few auras, but especially if we've kind of determined they are part of the evolution of symptoms, they are still small seizures. They're focal aware seizures. Generalized epilepsies often are not associated with an aura, but there are some patients who will say that they, even with generalized epilepsy, they can feel them coming on. Whether that's, they have a brief absence seizure leading up to a bigger seizure, or potentially a myoclonic seizure leading up to a bigger seizure, is probably less clear. And then the semiology of the event is highly dependent on the type of seizure, right? So seizures in generalized epilepsy will often have a quick evolution into the predominant feature of the seizure, right? So, quickly have this behavioral arrest with an absence seizure, quickly into myoclonic jerks or drop seizure with, loss of tone, atonic seizures. Whereas focal seizures are the ones where we may see this more of an evolution of symptoms, right? You get this sensory psychic phenomenon, and then you might have some motor activity after that, whether it's automatic behavior or unilateral posturing, head deviation, then proceeding into that predominant feature, which may be the bilateral tonic-clonic activity. And then, after the seizure is done, depending on kind of how severe the seizure is, that'll determine some of this postictal phase, right? The postictal phase could just be as simple as feeling drowsy, severe confusion. Sometimes you can get a postictal Todd's phenomenon where we're weak on one side and then we get confused and think that they've had a stroke. Sometimes it's speech deficits, which take some time to resolve. And then when we talk about seizures, we break them down into non-epileptic seizures, and then the bigger focus for this is going to be epileptic seizures. So in the non-epileptic seizures, there's the physiologic ones, the cardiac, drugs, metabolic, toxic, infectious. The non-physiologic are those, the psychogenic, functional, dissociative seizures. And then epileptic seizures, we have the provoked ones, alcohol, less so lack of sleep, but severe sleep deprivation could provoke a seizure. Drugs, metabolic, fever, infectious, unprovoked. And if you have recurrent unprovoked seizures, that's when we have epilepsy, and then we break it down into generalized and focal seizures. I'm not sure how many of you have seen this video. I find it a pretty interesting video to talk about seizure mimics. These were German medical students who essentially induced syncope, and some of the early ones I'll show you. Hopefully the video plays appropriately. Looks more like classic syncope, but then some people with convulsive syncope can often be confused for a tonic-clonic seizure, right?
And then quickly stand up and Valsalva as you stand. You will syncopize. So here's a healthy, normal German medical student syncopizing away. There he goes. He's taking a little longer than usual. There he goes. I want you to watch on each of these patients what their movements are like. So he's shaking.
So, sorry, I meant to go back here. So that was more of a class, some myoclonic jerks with that, but a syncopal event. And then there's one toward the end here.
If we're asking these patient family members who are freaked out, watch her. She's this is a normal person. This is you. You can do this too.
Yeah. So that kind of shows you that some of these episodes of convulsive syncope can be confused by family members and oftentimes even doctors, right? They'll see these episodes and say, oh, the whole body was shaking, it looks like a seizure. But then when you get the history of, whether in this case they were valsalving, but their progression of symptoms was much more consistent with a syncopal event, and maybe there's no postictal state, and that gives you a little bit more information that, what this was more consistent with a convulsive syncope. And then, as I discussed a little bit before, when we have our generalized seizures, and when we talk about generalized seizures, it's not really the whole brain, but it's bilaterally distributed networks involved with in the brain that will cause these seizures. But we have generalized tonic seizure where the whole body gets stiff, clonic, which is this rhythmic jerking, and then tonic-clonic, you get that progression. The classic old term for it is grand mal seizure, where your whole body gets stiff, and then you have clonic activity, and then myoclonic seizures with these more jerky, less rhythmic seizures, absence seizures, which are these brief behavioral arrests, and then atonic seizures, the loss of tone, or other term for it is drop seizures. And then we have our focal onset seizures, which will start in one part of the brain, one hemisphere, and then they may spread to then have widely distributed networks involved. And then when we have those with retained awareness, we have the motor seizures and non-motor seizures, right? Motor seizures could be as simple as automatic behavior. Other times it could be posturing or clonic activity. And then non-motor, it could just be a psychic phenomenon and then a behavioral arrest. And then some may have impaired awareness with these, and again, motor and non-motor involvement with their seizures. And I alluded to this earlier, that the ILA likes to really meet every few years and change how we classify our seizures. I think the newest terms are the most helpful. We used to have our old terms for seizures, the grand mal seizures, then you had the petit mal seizures. Then we changed them to dialeptic seizures for these seizures, focal seizures that had impaired awareness. And then we were starting to use complex partial seizures. But I think the newer terms are a little bit more helpful. This is the expanded terminology from 2024. I actually find the 2017 one, which I'll show later, a little bit more helpful than the 2024 one for some reason. But we break down the seizures into focal onset or generalized onset and then unknown. This is kind of the basic version, which I think is a little bit more straightforward. And then, so we have I'm going to go to the 2017 because I think it's a little bit more straightforward than this. So this is the 2017, again, the expanded, and then this is a little bit more helpful, the basic version of it. So you have your focal onset seizure. Are they aware during this, or is their awareness impaired? Do we have motor involvement, no motor involvement? And then does it start focal and then go to bilateral tonic-clonic? And then we have our generalized onset, the motor ones, tonic-clonic, or other motor, or the non-motor, which are absence seizures. And then when we don't know the onset, is there motor or non-motor involvement? And then I think that's a much more simplified way of breaking down, what a seizure is when we see them and when they're described to us by family members. So what kind of investigations do we want to do when we see someone who's had a seizure? In the acute period, of course, they're going into the emergency department. Sometimes we're getting some of this on the field. Blood work, a glucose level, getting the kidney function, BUN, getting electrolytes, sodium, other electrolytes, urine toxicology, I think is something that often goes missed with seizures, but can help us out, especially when patients come in and say, oh, I don't use drugs, I don't drink. We take them at their word, but I think especially if they're coming in with a new onset seizure, it is a good idea to still get a urine toxicology screen. Prolactin levels, they have pretty significant limitations. There's some data that says that it can distinguish between an epileptic seizure and a functional or dissociative seizure. Other name for it is the psychogenic non-epileptic seizures. But the limitations here are you have to have a baseline. Typically, we look at 2 times what that baseline is that would indicate that it was an epileptic seizure. But then there's also data saying that you can see prolactin elevations in syncope. So it is a little bit limited in how helpful prolactin can be. Probably where it's more helpful is some of these inpatients who have come in and they're having all of these recurrent events. Are they epileptic? Are they non-epileptic? What we could do is we can get a prolactin level 6 hours after their last event, and that would be considered a baseline. And then if we get a prolactin level within 10 to 20 minutes after an event, then that's probably where the prolactin is going to be helpful for us. And then in the acute period, if we have some concern about an infectious process, a meningitis, encephalitis, or a subarachnoid hemorrhage, that's when the lumbar puncture can come into play. And then a CT scan, particularly if we're looking for a structural lesion, a hemorrhage, particularly if they've got focal deficits, prolonged altered mental status, fever, trauma, headache, and certainly if there's a history of cancer, anticoagulation, AIDS, and really anyone over 40 years old who has had a focal onset seizure. And these are for new seizures. If it's someone who has a history of epilepsy and they've had their typical seizure, but it's longer, we probably don't need that CT scan. EEG, of course, is helpful in the acute period, but within our limitations of when we can get these EEGs, probably inpatient is best reserved for those who are not returning to baseline. Otherwise, most can be deferred to an outpatient basis. Long-term, of course, we'll need an EEG, and then MRI to look for any sort of subtle structural abnormality, whether this is some kind of migrational disorder, whether this is related to something like a mesial temporal sclerosis. And MRI is going to be appropriate at picking up the etiology of their seizure rather than a CT. EEG, of course, has its own limitations, right? Because unless they're actively seizing, we're really looking for these markers in between, these intrarectal epileptiform discharges. And some studies show that, if someone is to have intrarectal epileptiform discharges with their seizure, about 50% of these are picked up with a single EEG. It improves with subsequent EEGs. Third EEG goes up to 84% of people are picked up with their third, and then about 92% of people will be picked up by their fourth EEG. So there's a lot of value in repeating EEGs, when there's a question about their epilepsy. And then, when someone comes in with epilepsy and has a seizure, before looking at, okay, let's bump up their meds, let's start a new medication, we should be looking at what their common or what triggers they may have. Most commonly, missed medications, very poor sleep, if there is an illness, and we know that fevers, other sorts of infections can decrease the seizure threshold and increase seizures. Stress is a tough one. Probably stress in itself, I think sometimes some patients will overemphasize that, oh, this happened due to stress, but stress can then lead to poor sleep, and yes, stress can increase seizures. And then alcohol and drugs, of course, if especially with alcohol, 1 or 2 drinks probably shouldn't do it unless some of the genetic generalized epilepsies are very sensitive to alcohol, and even a couple of drinks may increase their myoclonus. But for the most part, for adults, if they've had 1 or 2 drinks, it's usually okay. It's really these binges, because alcohol itself can reduce the seizure threshold, but then alcohol will also lead to very poor sleep. So it's kind of a double whammy. And then, illicit drugs, cocaine, methamphetamines, all of those are going to reduce your seizure threshold. For certain members of the population, there are hormonal changes that can increase seizures, right? So menstrual cycle, catamenial component to epilepsy can certainly increase seizures. And then for certain generalized epilepsies, certain flashing lights at specific frequencies can induce seizures. Typically, we can pick that up with our EEGs when we do photic stimulation, if there is a component of a photosensitivity for their seizures. When someone's come in with a seizure and we've decided, okay, let's start some medications for their what we're now going to be terming epilepsy. There's different treatment options for anti-seizure medications, and then another aside here. With terminology that epileptologists love to change every few years. Now we like to use anti-seizure medication as opposed to anti-epileptic drugs, because the medications don't affect the epilepsy itself, but reduce seizures. So that's now why the terminology is switched. But yeah, we oftentimes we're going to gravitate to broad spectrum anti-seizure medications, because we don't know right off the bat if they have a focal or if they have a generalized epilepsy. So one of the reasons why Keppra or levetiracetam is so popular is because it's a broad spectrum anti-seizure medication. It's easy to start, but there are lots of other options, right? There's lamotrigine, valproic acid, topiramate, clobazam, perampanel, other name for this, Fycompa, are also approved for generalized epilepsies that are considered broad spectrum. Then there's the narrow spectrum, which are typically used for focal onset seizures. We tend to avoid these for people that we are concerned may have a generalized epilepsy, because certain generalized epilepsies may have worsening of their seizures with particularly the sodium channel blockers. So phenytoin, carbamazepine, oxcarbazepine, acecarbazepine, lacosamide. Those are all quite good for focal epilepsies, but they could, particularly with those that have myoclonus, could increase their seizures, and then even gabapentin and pregabalin can increase those myoclonic jerks. Lamotrigine is a tricky one because it's a sodium channel blocker, and there are some patients that might have an increase in their myoclonus with lamotrigine, but most do okay with it. And then we pick our anti-seizure medication, based on multiple different factors, right? Sometimes there are very specific scenarios that'll lead to us gravitating to certain choices. So if they've got comorbid migraines, we might pick something like topiramate or even gabapentin, pregabalin. And there's actually some newer data, I think, in the recent migraine guidelines, levetiracetam or Keppra is being used for migraines as well. So, that might be an option for people with migraine. Elderly patients who are a little bit frailer, maybe on a lot of medications, we may want to avoid some medications that have a lot of drug interactions. So we might pick something like a Keppra, levetiracetam, or gabapentin. Lamotrigine, lacosamide are also other medications that have relatively few in terms of medication interactions. But one thing to keep in mind with lacosamide in the elderly population, if they've got cardiac issues, lacosamide can prolong PR intervals. So maybe checking an ECG before and then after, just to ensure that there isn't any prolongation of PR would be advised. We should also be doing this with most sodium channel blockers. Now that we're seeing this as well with lamotrigine, it's been seen with carbamazepine, some cardiac conduction issues for a while now. And then another thing that we tend to see, because epilepsy and mood disorders coexist quite a bit, are comorbid depression. So for those people, we may look at lamotrigine, we may look at valproic acid. And then, for people who are on a lot of medications, there's going to be, every seizure medication can be associated with sedation, but maybe less so lamotrigine and Keppra. But I've had some patients who find even those excessively sedating, but maybe a different medication, not as much. So it's not really a hard and fast rule, but those are often good options in those scenarios. And then something that we're going to see in the hospital is status epilepticus, right? This is defined as 5 minutes or more of continuous clinical and or electrographic seizure activity or recurrent seizure activity without recovery between seizures. So basic management, right away, assess the ABCs, make sure we have IV access, make sure we've got a clear airway, getting oxygen. And really at the beginning, it's giving benzos, right? Benzos until we can get them to stop. And then sometimes that might cause excess sedation leading to intubation. Unfortunately, they may need to go to the ICU, but the earlier we treat the status epilepticus, the hope is that we will we'll prevent a prolonged admission. So really try to stop this in its tracks as early as possible. And then once we've stopped this acute period of seizures and maybe the benzos haven't worked, we might want to start an anti-seizure medication, and then choosing a maintenance anti-seizure medication. For most people who already have epilepsy, it's getting them back on their home medications, especially if they've presented in status epilepticus because they've been non-compliant or missed medications. Often just getting them back on their medications will stop their status epilepticus. And then one thing that we've run into here in Scarborough is some IV access for medications, right? So if the patient has oral access, we have a lot of options for giving them medications, with most of the anti-seizure medications, the oral absorption is pretty good. And if we can get even loading doses of some of these anti-seizure medications orally, that often is pretty good. But then with IV options, they can sometimes cause infusion reactions, but if they are in status epilepticus, that's something that we need to look at starting them on, whether this is IV phenytoin, again, restricted access to IV Keppra, levetiracetam, and then valproic acid we also have limited access to because of special access, but we do have access to lacosamide and phenobarbital. I think this is a really helpful algorithm that is on the AES website for the management of status epilepticus. I think helpful for more so emergency department physicians and the ICU, but pretty much goes over what I'd mentioned, assessing your ABCs initially, getting a blood glucose. If they're deficient, you want to give IV thiamine first, then glucose. And then, like I'd mentioned, giving benzos, and a lot of that can depend on access, right? If we have IV access, we're giving mostly IV lorazepam here, but you can give midazolam, diazepam. And then from there, you can load with different IV options, and I went over some limitations that we have in terms of our IV options, and then starting a maintenance therapy. And then if all else fails, they may have to get sedated with a drip such as propofol, midazolam, or phenobarbital, or occasionally ketamine. So these are the levels of evidence for treatment for status epilepticus. We gravitate towards lorazepam and midazolam, probably the best evidence available for those. But there's evidence for all the rest of these listed here as well. Another important topic, which more so we run into on the outpatient basis, but it's important to address on the inpatient basis as well, is impact of driving and seizures and epilepsy. I've worked in a lot of different places. Ontario is mandatory reporting. I think that really actually hurts the patient-physician relationship. I've worked in BC where there isn't mandatory reporting. I think Pennsylvania had mandatory reporting. Texas didn't. There's been a lot of studies on mandatory reporting and does it affect risk of accidents. It doesn't at all. It's if patients want to drive and they've had seizures or epilepsy, they're going to drive anyway, whether their license is suspended or not. It doesn't really make much of a difference. What it does affect is the patient-physician relationship. You get a lot of patients being withholding, not kind of telling physicians when they've had seizures, because they want to get back to driving, because driving is a very important part of life, right? But it's important to address in the inpatient setting, because then there's realistic expectations when we're seeing them as an outpatient, right? This is from the CMA, their driver guidelines. So, the MTO slightly differs from the CMA guidelines. It's not a whole lot different, but, for the most part, a single unprovoked seizure before a diagnosis. It's no driving for at least 3 months, but also a neurologic assessment with a normal EEG and appropriate imaging. It doesn't have to be an MRI. Usually, at least with the MTO, it's usually about 6 months, even with a single unprovoked seizure. In certain cases, I do kind of check that little box for 3 months is okay. I more so will do that if there was some kind of provoking factor. If it's truly unprovoked, I do tend to kind of say, let's wait until that 6 month mark. And then commercial drivers is going to be a different story. And then certainly if there's a diagnosis of epilepsy, it is 6 months seizure free on medication. And then we have this vague insight into patient compliance, and then we've counseled them on alcohol and fatigue. And then there's very special populations of after surgeries, 12 months, and then you'll sometimes in the inpatient setting get patients who present and they say, oh, I can drive even though I have seizures, because they only have seizures during sleep and immediately upon awakening. And that is true. If they've only had these seizures during sleep or upon awakening, and they've had that pattern stable for a year, they're still okay to drive. But then we have these patients who, why are they then coming into the hospital? Oftentimes it is because they've now had a seizure while they're awake, and they'll get a little contentious saying, oh, we should still be able to drive because, I was told I could drive with my seizures, but it has to be stable for a year where it's only in sleep or immediately upon awakening. And then when we make medication changes, whether this only applies to not adding medications, but withdrawing a medication or reducing a medication, we do need to observe for at least 3 months before it's safe to drive again. And then similar thing with seizures during sleep or immediately upon awakening. If people only have, and then they're using the old terms here, the simple partial seizures, but the focal aware seizures, if they only have auras, then they're still able to drive as long as there hasn't been anything for the last 12 months, which would prevent them from returning to driving. And then another thing that we're going to see inpatient is we see a lot of these alcohol withdrawal seizures. It's important for the patients to know that not only do they have to be seizure-free for 6 months, they have to be alcohol-free, and they have to actually attend some kind of rehab program or get some clearance from whether it's their family doctor or the rehab program saying that, yeah, they haven't been drinking, they're okay to return to driving. There are other conditions where it's good to observe people for at least a period of time where they shouldn't be driving. Syncope, if they've only had one, there really isn't a restriction, but there are other scenarios where we should be counseling our patients that, hey, even though we don't know, is this a seizure, is this syncope, we should at least wait kind of a week, whether it's just kind of a simple recurrent vasovagal syncope. But if there's unexplained syncope, we should still be waiting for about 3 months if they've had recurrent episodes. And then another special population doesn't, we might see this sometimes in hospital, because I don't know why last year I had, I think, 3 pregnant patients in like back-to-back months come admitted with new onset seizures. But people with childbearing potential and epilepsy, it does affect our anti-seizure medication choices, right? So contraception can sometimes affect our anti-seizure medications, because particularly with lamotrigine, estrogen-containing oral contraceptives can decrease our lamotrigine levels, and then vice versa. There are multiple anti-seizure medications that work on, cytochrome P450 that can reduce the efficacy of our oral birth control, and thus we need to counsel our patients on that. For the most part, with epilepsy, I tend to recommend IUDs for that reason. Folic acid is having its moment right now, because there's now newer evidence that high doses of folic acid could increase the risk of childhood cancers. So in the past, there was this recommendation, oh, you have epilepsy, you are on anti-seizure medications, okay, 5 milligrams of folic acid for everybody. And now we're tailoring it a little bit more. 1 milligram is usually enough for most, particularly if there's a single anti-seizure medication, and it's one of the anti-seizure medications that is not associated with increased risk for major congenital malformations or neural tube defects. But if there's one of those, we might tailor it to 2-3 milligrams. And certainly if there's multiple anti-seizure medications. And then I talked about this earlier, some patients will have a catamenial component to their epilepsy. Pregnancy, like I mentioned, I for some reason saw quite a few pregnant patients last year. Counseling for pregnancy, our goal is to be seizure-free during the pregnancy. Generalized seizures can be harmful to both mom and baby, so that may trump the risk of the anti-seizure medications during pregnancy. So counseling patients on that. Ideally, we can get all our pregnant patients to a single agent, lowest effective dose, minimize our risk to the fetus, and have them seizure-free. We often like to say, okay, seizure control before the pregnancy is higher prediction of what seizure control is going to be during the pregnancy. So if we can get to a 1-year seizure freedom before trying for pregnancy, that's probably advised. Most women may not see a change in their seizure frequency during pregnancy, but about a third will have an increase, and a little bit less might actually have a decrease in their seizures due to kind of hormonal shifts. Some of the increase is likely tied to changing drug levels during pregnancy. So we would like to get a baseline level pre-pregnancy, and then frequent monitoring, particularly early in their pregnancy. A baseline level for patients who are controlled is pretty important, particularly because in the first trimester, sometimes even before patients know that they're pregnant, lamotrigine and Keppra levels can drop pretty quickly early in the pregnancy. So trying to monitor their levels and compare it to our baseline and adjusting our doses is pretty important for these pregnant patients. Oxcarbazepine can decrease a little bit later, more like second or third trimester, but monitoring during pregnancy is important. During pregnancy, neurologists should be involved in a lot of these should probably be referred to a specialized obstetrics program, such as that at Mount Sinai. And then with breastfeeding, most of the anti-seizure medications are going to cross into breast milk, but often the side effects are pretty minimal. It's sedation, watching kind of sedation of the baby, and then talking to the risks and benefits of breastfeeding versus formula. And then generally in terms of the risk of fetal malformations for medications in pregnancy, they are dose dependent. So low risk, for most patients who are planning on getting pregnant, we often focus on Keppra and lamotrigine, but oxcarbazepine trileptal is also pretty low in terms of risk to the fetus. Then valproic acid is probably the highest, but that's quite dose dependent. Some studies show that less than 1,000 a day and ideally less than 500 to 600 may be safe. The reason this is important is certain generalized epilepsies really only get controlled with valproic acid. So, counseling patients on, seizure freedom with the valproic acid may trump the potential risks associated with the valproic acid use during the pregnancy. And then, when and who should we be referring, right? So if there's a new onset unprovoked tonic-clonic seizure, any one of us neurologists here at Scarborough will see them, set up the workup. Ideally, an MRI and EEG are arranged beforehand, so we can kind of start counseling about what to go from there. And then presume new diagnosis of epilepsy if they've had recurrent stereotyped events. And then, uncontrolled patients may need a referral to an epilepsy clinic, right? So oftentimes we look at a tertiary care center here at Epilepsy Clinic at Toronto Western Hospital. But, we have a growing number of community epileptologists as well that can see these people. Myself, Dr. Hopping here in Scarborough as well, sees these more difficult to control epilepsy patients, Dr. Berkovich in the community, Dr. Pelican, Dr. Lee. There's quite a few. There's a growing number of them, but ultimately some of these that need, particularly a surgical workup, may need to go to Toronto Western and get set up for epilepsy monitoring unit. London also has an epilepsy monitoring unit, so does Hamilton, Master, and Kingston. And then other people who are controlled, but they're developing long-term side effects to their medications, or patients with epilepsy and childbearing potential, and they want to plan pregnancy. There are a couple of specialized clinics for that. Dr. Bowie, her area of specialty at Toronto Western Hospital, her specialty is women with epilepsy and childbearing potential and pregnancy planning. And then Dr. Moore's at Mount Sinai as well, sees a lot of these patients. And then just general resources for epilepsy. Epilepsy Toronto is a great resource. They do great counseling. They have a lot of groups available. And another thing that they have that is often difficult to get a hold of is, epilepsy patients have a lot of comorbid anxiety, depression. They have access to therapists through Epilepsy Toronto, which is quite helpful. And then Canadian League Against Epilepsy, and then more sort of informational things. Epilepsy.com is a good resource for patients sometimes if they want to read more about epilepsy. And then more so for practitioners, American Epilepsy Society has a lot of guidelines for management of epilepsy and seizures and all that fun stuff. All right, so that's me. That's done. Does anybody have any questions?
I think people are probably getting back to business, Abhishek. Thanks a lot.
Yeah.
It's Derek here.
Yeah, I figured. Thanks, Derek. All right, bye, everyone.